So only three very important clinical signs. That is reduced chest movement to this side. You can see this. Now this is hyperinflamed lung. Chest is moving normally now. You can see this. Usradri. Just see this. Now this lung is moving normally. But in this lung there is a movement is reduced as compared to this side. So comparatively there is a reduced movement here with the formation of percussion here tympanic node, here stony dull node, here tympanic node, stony dull node. So this is second feature. One more feature is on auscultation. There should be Usrad. Air entry is there here. Usrad. Air entry is absent here. Usrad. Air entry is there here. Usrad. Air entry is absent here. So these three are the very classical triad of you can say classical triad also. You can say these are the classical triad of the pleural effusion. So we diagnose that from clinically we have diagnosed the pleural effusion now. So what you have to do is we have to tap the fluid and we have to send for fluid analysis to see whether it is a transudative or whether it is an exudative. From if it is a transudative means like usually transudative are mostly secondaries like failure features because of conjunctive cardiac failure, the fluid collection, because of severe anemia, maybe a fluid collection in the lungs that to cause pleural effusion. That too because of these are the whatever may be in the liver patient, in the alcoholic patient, in severe anemia patient, nephropathy patient, like in nephrology, the chronic renal failure patient. Because of all these conditions, if the pleural effusion is there means it is because it is called as transudative. There should be a protein, less protein, less everything. So in the same way, exudative means either it may be bacterial infection, either it may be any viral infection, either it may be a cancer condition. So what we will do, just tap. Okay, hold. So for the tapping, you should make there are two techniques of tapping we are there. On first one is like patient makes to sit in this position so that we will have some great exposure of the ribs from the backward. One more style is like one more method is we have to make the patient to sleep and we have to prick like here so that fluid will come now. Now he is having massive pleural effusion, fluid will come very normally. So what you have to do is first you have to clean the part. One more better. So because tapping is very important so that we will have so many conditions. If the protein, each content in the tapping, like whatever the sending for the analysis, there is something I have forgot to tell that. In some patient there are some clinical features. If the patient is bilateral, if the patient is having bilateral pleural effusion, most probably it may be because of the secondaries like failure features. Maybe in secondary to kidney diseases, acute kidney injury, that may form some problem and pleural effusion. And the patient is having severe anemia, that may form the cardiac failure. So because of this, there may be bilateral pleural effusion. So bilateral pleural effusions are most usually should not be tapped because these usually have some secondary because these are usually because of the secondary infection. So if the patient is having right side pleural effusion, this may be because of if the patient is having alcoholic like huge ascites, maybe right side pleural effusion secondary to alcoholic. If the patient is having left side pleural effusion most probably secondary to pericarditis and pancreatitis patients. So sometimes thoracic duct obstruction more than T5, okay, more than above the T5 level thoracic duct obstruction maybe there means they will have right side pleural effusion. In the same way, thoracic duct obstruction below the T5 will have left sided pleural effusion. These are the very rarest conditions. So we will have tap now. So what you have to do is we have to make some spaces. You can see this clearly. You can come here. You can see this clearly like scapular bone is there. You can feel this scapula. By anatomically, this scapular border, end of the scapula will be in the 6th to 7th intercostal space. So this just below this we can tap because of the 8th intercostal space. We can prick here so that we just before pricking we'll just percuss now. Yes, there is a stony hard dullness node is there, and we'll auscultate for the same. We are ausculting now. Usradri academic comment. Usradri. Now there is no air entry, so air entry reduced now. So what you have to do is, this is a point where you have to prick. Suppose sun choose re, sun choose. आराम से मकोर, आकार मुका मार रही, आराम मकोर राइट. हाँ मुझे नेट तो कंट्रोल नहीं आराम से, सीधा कोट. This position first you have to take 26 syringe with a big bore needle, pink needle. You have to prick the same way. I selected this intercostal space. Now I am going now. I am taking 20 cc because this may be enough to diagnose for analysis. See very carefully. Come here. Move it. See this fluid. Now it is coming. You can observe the fluid color. It may be like red color, like dark color, not totally red color, like chocolate color is there. So we took 20 ml fluid now. So what you have to do is, suction machine. So we are starting from the suction machine. The fluid is coming now. You can show the fluid falling there. You can show some suction machine if there is falling out. You can go there. It's coming. It's falling. Coming now. We are tapping now because like there are some complications of the tapping. Verify my full injection tremor. So there are complications of tapping. Like if the patient is having chronic smoker condition, now there is a dark color fluid. It is a very very warm fluid.